Okay, so good morning everybody and welcome to Barnsley CCG Governing Body in Public meeting. Welcome to members of the Barnsley public. So housekeeping, we're on Microsoft Teams. Those of you that are in Hilda House, there are no alarms or anything like that expected. So we move on then. Apologies, Kay.
We have apologies from Dr. Jamie McInnes.
Yeah. Okay, and we corate.
We are.
Good. And if we can then move Jane to the patient story, please.
Okay, thank you, Chair. So as per the paper on today's agenda, the governing body will be aware that the CCG has developed a new service specification for people with respiratory conditions in Barnsley called Breathe. A significant part of developing the service specification included engagement with people who have respiratory conditions, their carers and family members, members of the public, healthcare professionals and key stakeholders. The aim of the engagement was to seek people's experience of the current service, what they liked about it and what they thought could be better, and also to ask people to consider our proposals for the new service, whether anything had been missed or should change. The engagement showed that overall people supported the proposals for the new service, which were care delivered closer to home, that the service will be integrated by combining specialist respiratory nursing and clinical skills and together with GP practices and community services, providing people with confidence to manage their conditions at home where clinically appropriate, supported by the revised Breathe team. The You Said Our Response document, which is part of the suite of papers, highlights how the feedback from over 50 individuals has influenced the specification. Today's patient story articulates the catalyst for change. Reflecting upon the key changes in the new service specification, it shows how the new service will support people like Ellen and also her family. Thank you, Dan. You're on mute, Dan. Thank you.
Hi, I'm Darren. I'd like to talk to you about my mum, Ellen. She's 71 and she's just been diagnosed with COPD. When she was diagnosed, I'd never really heard of obstructive pulmonary disease. I thought it was something that minors got. Then they told her what it actually meant, and I just thought it was an illness that she'd have long term. I didn't realise that at any given moment COPD can take control of or ruin your quality of life. I mean, it hit her pretty bad, if I'm honest. I don't think she wanted to let on. I mean, she's not the sort that wants a fuss. She was a single parent who brought us up and worked extremely hard. And she's got several grandchildren and she dotes on them. When they told her what she'd got, she told us she wasn't about to give up on life just because she had COPD. If her illness hadn't forced her to retire from a job at the local school, where she'd worked for 25 years, I've no doubt she'd still be on the playground today. But well, fast forward 6 years and it's like she's a different woman. She doesn't live that far from us actually, which is good, particularly when things get bad. I work full time, but there's usually one of us, me or my partner or one of the kids, who goes up there twice a day because she's on her own. And well, I mean, it all depends on how she's feeling, to be honest. She gets shortness of breath and she has good days and bad. She tries to do a bit of exercise. I think it's to get her out of the chair more than anything. She's not in the garden like she used to be, and she can't mess around with the grandkids either. Most of the time, she uses a frame to help her move around at home. When she has an episode, you can see it in her. I mean, she's wiped out for weeks, and she's been in and out of hospital so much. I mean, they ought to reserve her a bed. At the minute, when I'm worried about her coping with being on her own, now, I know that sounds daft. I mean, she's on her own all the time, but well, she's told my wife that she's struggling to sleep, and she keeps having loads of, she calls them what ifs, going around in her head. You know, what if she gets worse this winter? What if she ends up in and out of hospital again? I mean, stress isn't good for her. My wife asked her to tell the team at the hospital to see if there was anything that they could do. To be honest, I mean, we've no idea what's happening when she sees them up at the hospital clinic. She says they're a great bunch and they're happy with her. But if we could be a bit more involved, we might know how to help her a bit more. Or at least perhaps spot some of the signs. We get support when she's bad, but I'm sure there's more to be done to keep her on an even keel. She manages with this 24/7, but you do feel a bit helpless when things go wrong. It's like the last time we took her to the hospital for an appointment. I mean, by the time we'd parked up and she'd managed to get across that car park, that was all she could do to get through her appointment. So, I mean, I don't know if she said anything about her not being able to sleep and the what ifs. I don't know if she did or not. I mean, we live about 10 miles from the hospital, so I have to take half a day off work to get there for the appointment and then back again. It's not that I mind. It's really hard to get the time off work, and every time she goes, it puts her back again, and it takes days for her to recover, and well, then the worry starts again. At least if she has an exacerbation, well, then we'll give the GP a call. It's bad enough that we'll go straight to her knee, but well, you want to be at home though, don't you, when something like that happens?
Okay, thank you. Any immediate comments, thoughts, reflections? Madri?
I think for me, the biggest thing was the impact of the diagnosis on the lady, and also the big gap between the acute exacerbations and what happens when she is not that ill, what to watch her and how to manage at home, and prevention of admissions. And there seems to be a big gap there, which looks like there's a little bit of a gap which is missing. So this particular patient is not empowered to know what she needs to watch for and how can she manage things in between exacerbations, and also the prevention towards exacerbations. So that was sort of what was very evident there. So yes, she was getting treated when she was going into the hospital, but what happens between those hospital admissions and how does she manage her own clinical condition seems to be a big gap for me.
Okay, any other, thank you, Madri. Any other thoughts? Jamie?
Yeah, so probably a little bit more subtle in there, but something we've probably talked about before, but a bit about the what if thoughts. So what if I get worse this winter? What if I get elsewhere? And I was just thinking about the other support. So when we think about, and we've touched on this, our sort of physical health services, how we make sure then there's the mental health service link in there, and the sort of the input of IAPT or other services to support people with long-term conditions, including respiratory, who are perhaps going through them thoughts, getting a bit sort of stressed about what the impact can be, just to provide something additional. So that sort of came out there as well, and probably something we just need to make sure that we pick up as we move forward with that.
Thank you. I think there is psychological support in the spec. Certainly we've discussed it before, because patients get very, as we would, very understandably anxious if they're breathless. It's a horrible feeling.
Yeah.
And that makes you breathe deeper and exacerbates the underlying COPD and the lack of oxygen getting into the lung. Chris? Chris?
Yes, it brings home to me as a lay member the quest of care closer to home. There was the explanation that this particular patient lived 10 miles from the hospital, and by the time they got there, by the time this lady walked across maybe quite a long open car park, it put more and more stress on that lady. And by the time she did what she needed to do and got home, it probably, without putting words in anyone's mouth, it probably took a couple of days or 3 days to get over the actual procedure that was there to help her. So care closer to home is the one I'm hanging on at this moment in time.
Okay, thank you. Dr. Addy Conley.
Thank you, Chair. What comes to mind here, and we've talked about this several times, is empowering patients, and not just the patient alone, actually the people that are around the patient. This lady has got a chronic disease that is getting worse every day. There's only so much that she can do by herself, but the people around her are more than willing to support her to get through this. So actually, empowering the patient also involves empowering the people looking after her, who are very enthusiastic to actually do something to help her, to prevent her from getting back into the hospital at any point when she starts coughing abnormally. So that's something that came out to me here, empowering patients and their carers, really.
Yeah, that came across very strongly to me from that story. The family's wish to be involved and to know what to do. Mark?
The other thing that struck me is actually this is the sort of situation that may well have suffered during the current pandemic, is that these sort of reviews and supportive care might well not be happening or have been happening over the summer.
Okay, anything anyone else wishes to say? No, so thank you, and I think we've got Breathe, and it's down as the specs in here and updates on the procurement as we go forward. So thank you, Darren, and our intention as a governing body and a commissioner is to fill those gaps with the Breathe respiratory service. Thank you.
Thank you.
Right. Okay, so we'll move on then to item 5, declarations of interest relevant to the agenda. Does anybody have any new ones or any updates they wish to share? No? Okay, let's move on then. Item 6, Kirsty, patient and public involvement activity report, please.
Okay, so that patient story fits in nicely with what we've just been covering. So in the involvement and engagement report this month, we've got a couple of items focused on the Breathe service and also people's experience post having COVID. So, you know, what sort of respiratory services we might need in place. So I'm not going to go through the whole report, but I think there are a couple of things that I just wanted to tease out from that. So we've got the full engagement report on the website, so that's available for people to see. But some of the things that came out, some of the things that we heard in the patient story today, I think were reflected in the discussions afterwards. So I'm really pleased to see that. And we based some of that story actually on real Barnsley people's feedback. So actually what they're telling us is what we're seeing in that patient story. Lots of things there are about confidence, particularly when people are using oxygen. We had a lot of feedback from family members as well. And actually where people have got family members and they've got that close level of support, it feels very much as if it's a family condition, and actually everybody wants to do their best and wants to feel empowered to actually do something to manage this condition. So I think that's really positive that lots of people out there have got support, and that came across. Something else that came across that was quite interesting was I I suppose how the conversation took place within their GP practice about a breathe service, or when they went to the hospital about a breathe service. And it came across that people who'd had the condition for quite a long time didn't know about it. And it wasn't that they didn't know what it was called. They were like, well, why weren't we told about this before? Because this would be great. And actually, would this be something that we could use in the future? So I think there's lots of appetite there for the service. And when we played back to people about this is what we've got in mind, this is the model that we'd like to see in Barnsley, that was really well received. So I think that's a real positive. And we've got some really useful insights there that we've fed back into the service specification. So lots of positives. I want to say thank you to everybody that did take part, because obviously it's quite a challenge at the moment going out and talking to people and you know, getting feedback, but we got lots of feedback, so thank you to those people that did that. So that covers the breathe service. And then the second one that I've highlighted here is the very beginnings of work with people who've had COVID, family members again, to look at what sort of respiratory services and support might be needed post-COVID. And obviously that's, you know, completely new area of work for us. So we'll come back and report that at future meetings, because I think that's certainly something that, you know, that's not going to go away, is it? So we'll see what sort of things people are saying to us there. So they're just a couple of highlights of things that we've been doing. There's lots more that is taking place, but I just wanted to bring those two forward for this meeting. So thank you.
Yeah, thanks. I think I'd like to echo the thank you to those who contributed during this difficult period. I think that they made an effort to support us. Chris, you had your hand up.
Yes. Bear in mind this meeting is being recorded for the members of the public to look at it in their own time. Could we explain what BREATHE actually stands for? Because it does stand for something, doesn't it?
Right, John Harbin here. You should be able to do that, John.
The Barnsley.
It's the Barnsley Respiratory Assessment and Therapy Service.
That's right. So it's a condensed acronym sort of thing of that.
That's it.
So respiratory, and so there is one thing about this, Kirsty, that just struck me, and that is, and it comes back to Jamie's point about the psychological support, and it might be that we link people to the psychological support and the breathe service at diagnosis. That might be a piece of work, because they may not, that may be when they've got a lot of questions, they may not need a lot of the service at that point, but they will know about it. So I don't know if that's actually in the spec. It's certainly something we can do in primary care when we make the diagnosis, and easily enough in secondary care, just to hook people into the service. They won't all need a lot of input at that point, but I'm sure at diagnosis they will have a number of questions. So maybe we just need to consider that.
Yeah, and some of that did come out in the feedback, actually. It's quite interesting, and particularly we heard in the patient story, didn't we, about, you know, this isn't going to defeat me. And for some people, it was quite a surprise to get that diagnosis, particularly of COPD. You know, they'd been poorly, but you know, they hadn't been expecting it coming, and they didn't really know what was coming ahead either. So yeah, we definitely saw that come out in some of the feedback.
You've not read the spec. We're well ahead of you. That's included in the spec.
Good. Remember, we put the spec together, John, a couple of years ago. So yeah. Well done to everybody. Thank you, John.
We refurbished it, didn't we? So that's all in, and post-COVID care is also in there.
Thank you. Are there any questions, Kirsty?
Nick?
Yeah.
Stop referring to the breathe service in the new spec just relating to COPD. Yeah. It's a respiratory service.
And a post-COVID complication service as well.
Respiratory problems. So I know initially when we did it, it was worked out as a COPD service. This is now a respiratory service. So it should cover all facets that you're discussing now and that you've mentioned in your survey. And the spec reflects that.
Good. Okay, so if there are no other questions for Kirsty, we'll move on to questions from the public. Kirsty, have we had any?
We haven't had any this time, no.
Okay. So then we'll move on to item 8, which is minutes of the meeting held 10th of September. And they're there for any comments, any clarifications, and to approve. So taking them as read, are people happy with those minutes? Yep. Okay. Okay, so we can approve those. And that takes us on to item 9, matters arising report, where we look at the outstanding actions and their completed activity and any that are outstanding. Anything on the matters arising report?
I think there's somewhere where I'm supposed to be talking to Chris Lawton. I think so that conversation has never happened.
Yeah, I was going to bring that up later on in the agenda. There's something about medicines optimization, QUIP, and yourself having a conversation, and we've sort of noted that on a number of occasions. I think it's in, I don't think it's actually Matters Arising, it's somewhere else, but I have seen it, and I think we'll pick that up because I think that needs to happen. We've probably
sent emails to Chris, but Chris has never got back to me.
Right, but I think it is important for us, so we need to make that happen, because I think we've had it at a couple of meetings, different meetings, not governing body meetings, where there's an action to discuss medicines optimization with Chris in the context of QUIP as well. And I think, John, when we come to that later on in the agenda, we'll just take it as read from this point that you will make that happen. I think it needs to be a priority meeting. Okay, if there's not anything else on matters arising. Okay, the only thing I picked up was 190913, suicide prevention plans, and that's still outstanding. And I just wondered, given the suicides that we've seen when people are getting severely depressed in COVID, whether we need a bit of update around suicide statistics locally and what the mental health services might be doing differently, if anything, to support those people. And it would be good to have that on next governing body. So if we can push that back, I think it might be Mark Smith, something for you and Patrick to prepare a short report. Just the biggest morbidity from COVID is the general decrease in mental health in the population, but the suicides become something that are obviously deeply personal and damaging to families. And I wondered if we could just have an update on that for next governing body, perhaps.
Yeah, I know Patrick attends something on but they, fairly regularly, but it usually falls on a Friday. But I do get some output from that.
Yeah, so if you could ask him to do as a very short update, that would be helpful. And maybe tying that the other point that's on Matters Rising, which is something about updating on bereavement services, and I think both of those could have a sort of COVID reflection on them, especially with bereavement. So people normally would, if they have family and friends, they would be close, they would be meeting, and they're not allowed to now if they're outside the bubble. So it may be a bit harder for people. So I think it'd be good for us to perhaps on suicide action plans and bereavement, just an update, certainly to next governing body from Patrick. Doesn't need to be long and detailed, but a bit of an update statement.
Okay.
Okay, thank you, Mark. Okay, can we move on to item 10 then, please? Chris, Chief Officer's report.
Thank you, Chair. So I guess people know about this. I'm just more for formality, really, is that we went into a further lockdown on the 4th of November as a country. And what that means for the NHS is that we go back to level 4 in terms of our emergency preparedness. In practice, what that means is we head into a command and control system. So rather than organisations managing their own governance and control, we are now in a national control environment where NHS England and NHS Improvement direct us to act. It worked very well in wave 1, so I think I welcome it certainly in terms of wave 2. Certainly for Barnsley, I'm sure as we go through, Barnsley has been specifically hit by wave 2. So from our perspective, the lockdown and these arrangements, I think for Barnsley really do make a lot of sense, and I personally welcome them. So I'll just see if anyone's got any questions on that, Chair, before I just move on. Is everyone okay with that? It's pretty straightforward, and like I say, it did work very well for Barnsley in wave 1, so hopefully we can take the learning from wave 1 and manage successfully in wave 2. Just a couple of verbal updates, if I may, Chair, just around some appointments we've just made. So obviously I started on the 1st of September. I've come into a very successful, high-performing organisation, but we're heading into very challenging times, and undoubtedly in the nature of the NHS, there'll be a lot of change, I'm sure, over the next year and beyond. So just made a few changes to the structure, no major changes, but I'll just give a quick summary of the changes that we've made. So Jeremy Budd will be the Director of Strategic Commissioning and Partnerships. Jeremy will continue leading on the development of integrated care in Barnsley, continue leading on the joint commissioning development in Barnsley. Jeremy will make sure the CCG is fully engaged in our South Yorkshire and Basildore integrated care system. And obviously Jeremy will lead on strategic planning as well, amongst many other things, I'm sure. But just Jeremy's continuing much of the good work he's been doing today and just further clarifying the role. Another role we've moved in the structure is be a Chief Operating Officer, which Jamie White will take the role of. That role will be for the day-to-day running of the organisation, leading on transformation and operational planning and ensuring that all statutory duties are met. So the day-to-day focus and face of the running of the organisation. And last and definitely not least, I'm pleased to announce we've appointed to the medical director post, and Dr. Gunter Muckler is successful in that post. I think we're still sorting out arrangements for when we start, but the key role of the post, I'm sure you're all familiar with, but leading on primary care quality, health inequalities, and many other things, I'm sure, as we come along in the development. What I will do is I'll write out formally to governing body members and all staff, just clarifying arrangements shortly, so just so you can get that detail, because I realise I've just done a very quick summary. I'd expect that to be going out this week, that summary, so you'll see it. But if anyone does have any queries and questions, I'm more than happy just to pick up a conversation outside of the governing body, Chair.
Thank you.
So I'll just stop there, see if there's any questions.
Chris, just when you write out, it might be an idea to write out to the members.
Okay, thanks for that advice. I will do. Thank you.
Okay, any other points? No? Okay. Can we then move on? Thank you, Chris, to item 11. COVID-19 response and phase 3 recovery update. I think we've got Jamie and Jeremy down.
Yes, so I'll start off, and then Jeremy's gonna just share, I think, some slides and talk us through where we're at in terms of our reset plan. I guess it's worth just flagging things move quite quickly in the world of COVID response, as we all know. So from writing this report, we've probably tightened up a little bit and got quite pressured across the system. We'll be talking about that in a bit more detail later on, but just by way of introduction, because the paper sort of talks through the national position and references where Chris has just done so around moving back to level 4 command and control. But just in terms of the current position in Barnsley, I think it is worth highlighting that at the moment it is very challenged, both from across the acute trust right through. But yesterday, for the first time in all of the time that I've worked here, and probably all of the time that the CCG's been in existence, Barnsley Hospital had to declare that they were at a level 4 OPAL level. So we've been at level 3. It's been pressured in winter before, but to move to level 4 is a significant decision, because it requires sort of escalation then to NHS England regional team, and inevitably filters through to the Secretary of State, and therefore there'll be lots of people looking in to Barnsley to make sure that we're working as a system well. So that happened yesterday, and the main reason for that was their occupancy levels, particularly of patients with COVID. So the hospital have got around 40% of their beds occupied by people with COVID. Staff absence rates, so a significant proportion of their staff off, and of those off, around 60% of them are nursing staff. So that's creating real pressures across the trust, and there's been an ask out from the system to try from Barnsley, where we've got registered nurses, but also across South Yorkshire and Bassetlaw as well. And then the other issue, which was sort of prevalent a little bit when we were in wave 1, but resolved quite quickly, but is now becoming a problem again, not just from Barnsley but across the country, is the oxygen supply. So risk there in terms of the level of oxygen supply that's left. So that's been escalated as well. So that's the main reason that we went to that level yesterday. Across partners, I think the biggest risk that people are identifying is similar in terms of staff absence, linked to either positive tests or isolation because they've been contacts or other things. So I think it's quite a tough situation, and everybody's working together on that, and there's been some real positive support from right across the system, inside and outside Barnsley, including yesterday support from our neighbouring acute trusts to support by taking some of our ambulance patients in, but also by social care working differently in reaching to the hospital, providing additional capacity, using some of the funding they got for winter to provide additional contracts with home care and domiciliary care providers, but not to provide that service, but to link in with our community service teams to provide extra support into the rehab services, so support workers and things. So that resulted in the day before yesterday in managing to discharge 103 patients from Barnsley Hospital, which again, that only normally happens on sort of Christmas Eve as patients are wanting to go home. Still leaves them in a very difficult position. So yesterday morning there were still 20 odd patients then that had been identified as medically fit. So I'll leave that position there, and we will touch on it again later. I think just in terms of general infection rates and things, just for governing bodies, so that the overall rate is beginning to reduce. So we are seeing hopefully a slight reduction, although it's been described more as a sort of plateau, so it's not gone down consistently for a long enough period for us to take much confidence yet, but hopefully it's going in the right way. The numbers this week in ITU, so the really poorly people, is starting to sort of slightly reduce as well. But as I said, the numbers in the trust, the bed base, the numbers with COVID is continuing to increase. So still very much with us. So just in terms of the paper, reference there in section 5.1, moving to level 4. You know, as we've led up to this last couple of weeks, a lot of time and effort across the partners. So with Jeremy sort of leading and supporting and cajoling and bringing us all forward, has helped develop the reset plan, which Jeremy will share. Command and control, we're keeping a sort of sensible view on that. So whilst there's lots of pressure at the moment, we've stepped some things back up, but we're trying to make sure that we step up and down as appropriate to make sure that people are able with their jobs and responding and the reset stuff where that is practicable. In terms of service changes, I think there's probably just 4 to reference in here, and I'll try to elaborate a little bit more. So just we get caught up in the detail, and we're working so quickly that all of the references I make in here, when I write the report, instead of thinking, yeah, we know what we're talking about, so I'll just elaborate to clarify for governing body members and also for members of the public on some of these areas. So firstly, the primary care COVID services, so reference the continuation of the Blue Clinic. Our Blue Clinic is the clinic where we see face-to-face patients, face-to-face appointments for patients who are either COVID positive or with symptoms, to help to protect our other practices and keep them sort of COVID free. So that's been extended until the end of March now, to make sure that we've got the support going through. We've extended some of the arrangements around intermediate care. So the ACON unit, which is the sort of intensive rehabilitation unit that previously was located in the hospital, to free up space there, that were moved to Buckingham House, which is a residential care home where we provide other intermediate care. That's at Penistone. We've supported some reconfiguration work out at Buckingham, which will enable a COVID secure unit, which means that patients who are coming in there who are COVID positive never have to come into any contact with the rest of the care home, and also the rehab staff that come in will also be able to get direct access into that unit without exposing others in the care home to COVID. So that's required some building works and other things. That COVID intermediate care unit will be taking patients from this Saturday. So there's been a bit of a delay there of a couple of weeks, but during that time we've been able to discharge to elsewhere, and there hasn't been any delays of COVID positive but medically fit patients waiting for intermediate care. So I think it's worth noting that. Additional COVID care home capacity. So there's been, and again, this is a national thing, there's been a push to designate COVID care homes to make sure that the homes are designated to receive COVID positive patients back out of hospital. So in the first wave, there was lots of press and news around COVID positive patients being discharged into care homes. This process is to enable and to ensure that any patients who are discharged, who are fit for discharge but are still within the isolation period or still testing positive, are able to be isolated and managed effectively in those care homes. So the process of designation is still ongoing, but we have been able to secure some beds at a residential care home that we used previously at the start of this, which is Mapleton Court, which is out at Grimethorpe, and that's enabling us to discharge patients rather than them being in hospital through the isolation period. So that's there. And then I think the other point is just around enhancement and further development of local testing arrangements. And that's moved a little bit over the last week as well, in terms of now beginning to have some access to rapid testing for some of our staff and also for some patients. So primary care through the Healthcare Federation, but also some of our providers have got access to rapid tests, which provide a result within 15 minutes. So they're able to use that to, confirm people are COVID positive and make sure they're isolated, but also to support some of our discharge processes. So where care homes, for example, are seeking further assurance that a patient has had a very recent negative test before discharge, they're able to do that in the discharge lounge at the point of discharge and say, yeah, we can confirm that. That's enabling us to discharge.
Jamie, could I just intervene there? Because
yes,
I think what I'd like to do actually is now take Jeremy's part, but then come back to you, because I think we won't have another opportunity on COVID in this agenda. If you could say a little bit about, because it would be of interest to the public, the vaccine and the sort of plans that we're in the process of developing. If you can have a think about that for 2 or 3 minutes while Jeremy does his bit.
Yeah, sorted. No problem. That's fine.
Is that okay? So I think the public will be looking for that. Jeremy.
Thanks, Nick. So I'm only going to spend 2 or 3 minutes on this. There's quite a detailed pack which you've got in your papers, which is the sort of accumulation of work over late summer, early autumn with our health and care partners in Barnsley, responding to the NHS Phase 3 letter. So that's when we're in a recovery and stabilisation period. Clearly, at the moment, some of that work is on pause because of the situation we're in with COVID. So what you've got in front of you is a plan at a point in time, pretty much the end of October, and really important to note that it has been co-produced and supported by our integrated care partnership. It's in two parts. So part one, governing body has seen previously, and it's been in public before as well. So it is the 5 priorities that we've agreed to focus on as part of our recovery process. That's on page 9, or page 57 of the pack, actually. And then on page 58 of the pack, there are key deliverables, again, set against each of those 5 priorities. And as an integrated care partnership, we are meeting weekly to review progress against those priorities and see where we are and support each other in the delivery of that. And that is a process that has been going really well. Clearly, our attention currently is on priority 1, which is continued COVID-19 management and the response to that as a system, which Jamie has been talking about just now. On the next page is how we're organised to deliver. It's quite complex. There's a lot of work ongoing. So the coordination is kind of the amber bit in the middle. But there's a lot of delivery groups who are actively meeting and pushing things forward. Looks like a lot of groups really trying to reduce duplication as far as we can, in that they all have their own particular tasks which they want to focus on. I think it probably just shows you just how much work is ongoing across the system and across the partnership. Highlighting some of the key system issues and constraints on the next 3 slides. Again, I'm not going to go through them, but clearly we are considering those, thinking about how we mitigate them as far as we can, working as a partnership of both commissioners and providers. So that's probably the key part of the pack for governing body to focus on, but there is a much more detailed section, part 2, which is the partnership response to the phase 3 requirements by area of focus. Looking at health inequalities, cancer services, planned care services, emergency care, primary care, community services, mental health, children and young people, and flu vaccination, etc. And also our care home support plan. So there's a lot of detail in there. And that is, again, has been the focus of our work, trying to coordinate that, make sure we're focused in the right way, making the most of people's time, rather than having lots of work which is not productive. And that's been the sort of the ask of the integrated care delivery group and the partnership group over the last few weeks. Hopefully, governing body find it of interest. It's just for noting, it's not for approval. It is a plan at a point in time. We'll probably refresh it probably after Christmas in the early new year, just to update governing body on where we have got to against the actions which are outlined in the plan. So really kind of back to you, Nick and Jamie, about any questions or comments on that.
Yeah, thank you. I think with regard to the recovery and reset plan, it's a lengthy document, but quite detailed. I think if people have got comments on that, I'm sure Jeremy would take feedback, as in fact would Jamie and myself. Can I take, so thank you for that, Jeremy. Can I take us back now to Jamie? And Jamie, I know, as we discussed a little bit yesterday, and I've subsequently done some reading, I think the people of Barnsley, the public, will be quite interested in the vaccine. How it's given, when it's given, and the sort of initial guidance that we've been given as to how to deploy it. And this is very early sort of guidance, but I think the public will be interested to know and assured to know that we're moving plans forward. Yeah,
I think that's fine, Nick. So we're just going to quickly to reflect on the plan that Jeremy shared when we discussed that with partners. So Jeremy said it's long and there's quite a lot in and it's detailed. And we said that as a partnership, so it looks a bit long and there's a lot in here, but I think that recognises how much is actually ongoing. Because when we went through with partners and said, so what's not a priority then? What are the things that we're not doing? Actually, we couldn't take anything out. So I think there's a recognition there that in the middle of sort of all of this, there's a hell of a lot still going on, so I think that's a positive. So in terms of the COVID vaccination then, so there's been lots in the press around this, and no confirmation yet. So I think that's really important, that the vaccine will be available in December. So what has happened is the NHS have been asked to plan for the availability of a vaccine from December. And the reason for that is, you know, if it does become available, when it does become available, the government, NHS England, and of course us, all think it's important to be on the front foot and make sure that we can get any safe vaccine out to our population as quickly and in the right way. So initially there was quite a lot of talk around doing mass vaccinations, so having big sites, big centres, regionally hosted and provided. That's sort of still on the table, but it's probably being talked about a little less now. So sort of smaller and more local is more coming through. So actually having sites closer to where patients and citizens live, as opposed to having lots of people travelling in to try and have, I don't know, a site in Sheffield for all South Yorkshire or something. So that's moving forward. And on Monday, I think there was a letter that were published and shared for primary care, and I think that really emphasises where the thinking currently is. And I think that is that whilst there'll be other bits of testing, nationally sorted stuff, some regionally sorted stuff, the biggest proportion of tests, I think the expectation is, will be delivered through primary care, particularly for the population which is the sort of over 50s. So we're currently being asked, you know, within the letter and in other guidance, to begin to plan for delivering the vaccine through primary care, working practices with PCN groupings and with other community providers. Now, within that, there's probably also an expectation that supply will not just be free flowing, so it'll be limited to start with, and if it does come in December, it will be small numbers, and therefore there's going to be some clinical prioritisation, which will mean certain cohorts of patients are offered the vaccination first, and it is offered, so the vaccine's not mandatory. I think the government's view is that people will want it. We'll see how that works through. Not confirmed yet what the cohorts are, but there's quite a lot of information out in the public that suggests that it will be NHS frontline workers and other healthcare and care workers. It will be care home population and staff, and it will be the 80 or 85 plus population first. So a relatively small number, but then building up and sort of getting up to a full scale in the early spring, I think, is the expectation. So the ask of primary care at this point in time, so there'll be an enhanced service that practices are asked to sign up to, and the ask is to practices to work with CCGs and the PCNs, practices to put forward an expression of interest or as a form to fill in, which says that they'd be interested in the enhanced service and that they've got access to a suitable premise. So we've got to designate premises. So we got the letter Monday. There's an expectation that we identify suitable premises to deliver the vaccine across Barnsley by Tuesday next week. So that's for the information back into the CCG. The CCG have then got to do an assurance piece of work against the premises that have been put forward. There's one criteria in place that cover size, the amount of space, storage, whether there's a facility to make sure we've got the sort of aftercare arrangements to provide, etc. We've got to get that back in by Thursday, so we've got a 2-day turnaround on that, and then on Monday, well, the 23rd, sorry, I'm not sure what day that is, on the 23rd, NHS England will confirm back out to us whether the premises have been okay, and that'll be informed by what they know about the supply of vaccines. So if we put too many forward and they can't get the vaccines there, then it might be a limited list expanding out. So a really tight time frame for that. And as yet, the detailed specification is not available. So it's a really tricky one for practices to sign up to. So in terms of the vaccine, the expectation is that the vaccine will be delivered in sort of weekly batches to primary care. So there's noise in the system about having to store it at -70, -80. I don't think that'd be a responsibility of primary care. So the vaccine will be delivered.
Do you want to come in at this point, Chris?
Yeah.
Let Jamie finish, Chair, and then I'll come in.
Okay.
Thank you. So we'll be delivered in batches of just under 1,000, and the expectation will be that any practice or any site will need to deliver that number or sort of bigger cohorts, but each week, and deliver working with sort of other practices within the neighbourhoods. The vaccine, again, not quite sure of the vaccine that will become available, but expectation that there'll be a requirement for 2 vaccines, so we'll need to work that through with patients and make sure that they're booked in, and that will either be at a 21-day or 28-day sort of separate period. And the current guidance is suggesting that would also need to be 7 days after or 7 days away from any flu vaccination. So that's the info on the sort of vaccine, what's being asked. I'll come back and just give a bit of thinking of the approach and the discussions that we've been having with the PCN and others, but I'll just stop there if people do want to come in.
I've got Chris and then John. Chris?
Thanks, Chair. I mean, this is fantastic news, isn't it? So I think I'm really delighted as well that the national approach now is focusing on primary care. I know it's daunting for general practice in terms of provision, but we all know that GPs in Barnsley have got a track record of doing mass vaccinations. We're just currently in the middle of a big flu vaccination. So I think in terms of primary care being the main focus, I think that is definitely the right thing for Barnsley. A couple of concerns, just please. I mean, Jamie flagged the storage being a big concern. The other one is the requirement for patients to be observed for 15 minutes after a vaccination as well, which changes our vaccination model from all previous exercises. The other thing, just to flag up, I haven't got the answer yet, but just to flag up, there will need to be a big conversation, nationally or maybe locally, about the expectations around GPs' workload and standard work, which we currently expect, because obviously the mass vaccination will take a significant amount of GP time and resource and GP nurse resource. So I think just to flag that up, they are conversations yet to be had, aren't they? Particularly around expectations around QOF, expectations around local enhanced services and local quality arrangements. So just to flag that up to governing body.
Yep. Thank you, Chris. John?
Yeah, I've got 4 questions. So first one, Roxana, is there any extra funding since we're in phase 4 for COVID costs, looking at our QUIP?
So there is some extra funding, John, yeah, for primary care.
Not for primary care, for the CCG, because we're rehiring homes. So that's going to be that will have a direct effect on our QUIP, because I think it was £64,000 a week last time for one of those nursing homes, for having a separate unit in there.
Yeah, so the council have funded the separate unit at the moment, John. Right. So we haven't funded it. They've used their winter funding to support that.
Okay.
With regard to the vaccine funding, it's a DES, and it'll be paid for the 2 injections at the end of the second. If people don't want a second, then there'll be a process to go through. There is an expectation that the organisation of this may have some impact on allocation, but I think what they mean is that will come from the COVID fund, because if we're organising at scale, there will be some extra costs there, but they may well be fairly minimal. So I think that's the only financial implication there.
Yep.
There's 150 million for primary care.
Yeah.
To cope with the extra costs associated with this, and that will go through. That's going to be divvied up via ICS, and they'll pass it on to the CCGs. So, second question, one of the criteria, and we now, as primary care, were all being allocated care homes.
Yeah.
So, my question is, the patients are fine, we can record that on our systems. How do we record the staff that we give vaccinations to?
Yep. So, and I think the answer to that, John, is at this point we don't know yet. There's an expectation that National will sort it, but it's not clear yet how we'll do that.
But it's something the primary care team needs to start looking at now. Because the last thing we want is hassle when we're going through a large workload of doing vaccinations. Because it's logical. You go into a home, you do the vaccination, staff members are there, do them as well. But then we don't want to jump hurdles when we say, well, we've done these and they're not our patients. So I think you need to look at that.
Yeah.
As far as the criteria for the flu jab, I find that for the vaccine, I find that strange, considering we've already done the flu season mostly, and the criteria are relatively the same. So most of our primary care sites will already have the facilities and the storage facilities to cope with that. So I think primary care team needs to look at that rather than reinventing the wheel, because we wouldn't be doing flu jabs if we didn't meet those criteria. They're relatively the same.
I think, John, just some of the stuff on that is around the supply of the vaccine. So what they're saying to us is that they would, if we said we wanted to deliver the vaccine from all practices, they wouldn't be able to supply the vaccine to all practices, and it's going to come out in batches of 995, and there may be some need to draw up the vaccine and to dilute it and mix it, so they can't get it. So over time, that might be the expectation, and when we get to the bigger proportion of the population, and maybe the under 50s even, it might be opened out, but it's to manage the supply a little bit at this point. And then the other bit that Chris referenced in there, which we've not had for flu, is the ability to monitor patients for 15 minutes after the vaccine. So there's a bit more space in terms of the requirement to allow us to do that, and that's an important part. But I will expand a bit on where we're at in terms of the thinking on the model in a sec when people have finished.
So we've got quite a few hands up now, and I'm sticking. So sorry, John.
Nick,
last one.
Last question. Chris's point of storage at minus 70 degrees, I think maybe a red herring, because the latest guidance is it when it arrives at minus 70, once you start using it, you have 5 days.
Yeah. If it was stored centrally, John, and delivered to us.
So the criteria will be storing it in fridges that have a temp range of 2 to 8 degrees. So if you get 1,000 doses in on a Monday, if you do as a practice, then you need to just logistically work out how you're going to get that many patients in that week.
Yeah, and that's the challenge for us that Jamie's alluding to, and that the primary care team and the PCN will help us with, John. Absolutely. Chris Millington, you've been waiting patient time.
Thank you. I've been asked a question by two of my neighbours, which I didn't know the answer to. And the question was, can I still get the vaccine if I've not had the flu jab?
Yeah.
Okay, thank you.
Dr. Addy Conley.
Thanks, Nick. Just looking at the logistics, and I'm sure there are lots of clever people that can hash out this logistics very well. Just to my mind, the way this vaccine will be delivered, and if we are going to be giving them in primary care, we don't have the space in practices to safely distance patients and ask them to wait for 15 minutes to observe them and be able to give this 1,000 vaccine in 5 days. We cannot do it. I don't know the views of my other colleagues about this. And maybe we need to be either through the Federation sourcing out a bigger place like the Metrodome Stadium. They can do a lot of people in that place. I don't know what the views of other people are, but I can't see how we can manage that, giving that vaccine in 5 days and be able to cover a lot of patients with safe distancing.
I think it comes back to the logistical management of this. So has everybody who wants to speak spoken? Chris, are you wanting to say anything else? No. Okay. Can we take our hands down then and go back to Jamie? If people
Mike's got his hand up, Nick.
Sorry,
Mike Sims.
Yeah.
Mike, have you got your hand up?
Yeah, I mean the figures are that of the people invited for 50% don't turn up. I would hope for COVID more would, but with this very short life vaccine, there's also the question of how much would be wasted of what will be a very valuable commodity.
Yeah, and I absolutely think that's not going to be the case, Mike, in Barnsley. We've got PCN accountable clinical directors, business delivery managers, a primary care team, a GP federation, governing body support around the logistics. I think it's a challenge for us in Barnsley, but I'm sure it's one that we can surmount without wasting any vaccine and getting to the relevant people. And I think one of the things is that it is a challenge. And when a challenge comes, people always look at the difficulties and issues, but I think we can work through them pretty confidently. Jamie, do you want to?
Yeah, so just in terms of where we've got with the model, so and recognising people's comments. So I think feedback from practices, feedback from the LMC as well, has been that individual practices, at this point, whilst they can do some, would struggle, as Dr. Adekunle has highlighted, in terms of some of the arrangements. I think because of the point I've made around flow and around the cohorts of patients, if we're only doing patients over 85, then I'm not sure any practice in Barnsley would be able to do 1,000 vaccines for that cohort of patients. So it brings with it some challenges. So therefore, the letter and the guidance is being presented on the premise that yes, a practice might sign up to the enhanced service, but they'd be working in PCN groupings, supporting and delivering the vaccine for the patients of more than one practice. So I think that's where that sits. So it says initially a site per PCN. Now we're in a bit of a strange position on that one, aren't we? That others of a similar size might have 5 or 6 PCNs. We've got 1, but there is some flexibility in it. So at this point, the Federation are going to be coming out and talking to practices around whether anybody feels they've got sites and other things. But because of the limited flow, the current thinking is to try to identify perhaps 2 sites. And it may be that if practices are not wanting to sign up for the enhanced service individually and to offer across their partners, that Barnsley Healthcare Federation could potentially do that through one of their practices on behalf of all of the other practices, as long as there's support from the other practices to do that and to help with the delivery administration of the vaccine. So just using one example, so I thought that we've gone through, because there's also issues around the premises. So the Metrodome, Dr. Adekunle, is an interesting one. We thought about that. When they looked at the mass vaccination sites, Sheffield Teaching Hospital tried to put forward Sheffield Arena at Doncaster Airport, and they got pushed back to say they couldn't use them sites and they needed to use NHS premises. So we need to just bear that in mind. So one of the ideas that's there is if, for example, the BHF Lunwood practice signed up, we could use Priory Campus, which is not being used in the same way as it is normally because of social distancing and other things. So there's space there. You could, within that one site, have, if we used, 4 vaccinators, 6 vaccines an hour, you can do 2,000 a week. And that would sort of flow through. So try and identify probably 1 or 2 sites to start on that sort of 85 plus cohort of patients, and then as more clarity becomes available on what this means for practices, how it works, try to expand it out, but start in a manageable way. Now, what we will probably need to do, and the bits that fall outside and are a bit more difficult, is so the care homes. So if we went with 1 site or 2 sites, practice sort of hosting that, I think there'd be an ask out for each practice to support the one that had signed up for the enhanced service in the delivery of the vaccines for the care home that they are aligned to, which John, you alluded to, Obviously, there'll be financial flows that need sorting out, and there'll be all the rest of it that comes there to make sure costs are covered. But that would be one area. And then the other bit is the housebound. And the housebound is the one that is going to be the most challenging, I think, because if we're in a site, either at a care home or in a practice or in another building, you've got patients sitting. For every person that's vaccinating, you're only going to have a group of 4 patients who are sitting at any one time, because they'd start to flow through. So that would work, and you can have somebody sat in that area who's got the right training. When we start to talk about housebound patients, it's probably only possible to do 2 housebound patients in an hour. So you've got to go, you've got to do the preparation, you've got to talk through, you've got to do the vaccination, and then the person would have to stay with the individual who's had the vaccine for 15 minutes before moving on. So we need to think about how we work with our partners on that one, and we've got some options around that. So community services I've supported with the flu vaccine. We just need to bear in mind what we said earlier about the pressures that all of our health and care providers are facing at the moment in terms of delivering normal service. And the other people who we can have discussions with, who are trained and able to deliver the vaccine, are the public health nurses who do some, the council support with flu, and also the school vaccinims team. So they're in the middle of doing the flu vaccines for children at the moment, but as that comes to an end, potential to sort of free up some capacity and have some flexibility there. So I think there'll be a need to work closely with partners on that bit. So right. So that's where the thinking is now, something more at scale with support. So practices coming together and using the sort of PCN infrastructure to manage the receipt, the processing, coming up with the booking, the sharing of information back into systems to make sure all the recording happens properly, which we've not got the details of yet, but doing that in a single consolidated way seems sensible. So that's our thoughts on that at this point.
Okay, can I take Mark's got his hand up. Mark?
You're on mute, Mark.
Given that the vaccines will be delivered to a limited number of places because of logistics, what would the feasibility of moving them between practice once they were there, so they could do more of their own patients and get around the idea, the problems with space that way?
Might be an option, I guess. At this point, the only limiting factor on that is that you can only deliver the vaccine from a designated site, and they will only designate sites based on where they can deliver the vaccine. So that's something we can take back and push back up the chain, and it might be something we can do later, because yeah, that would be an option, but at this point there's not the facility to allow that.
Okay, thank you. I think at that point we've done
I had my hand up now.
Okay.
Taking Evo's point, since we at our practice we've completed our flu campaign and used all the flu jabs we had a meeting yesterday, and we decided if the practice received 900 jabs or 1,000 jabs a week, we could do 200 a day with 3 vaccinators. And as Jamie says, the throughput would work itself. So we're quite happy to do that because we've organised ourselves and we know how we would do it. So I'm not sure how other practices would do it, but I think the other thing you need to realise is you talk about a cohort of over 85s. That becomes relatively small if you do it by practice. Yeah, if you start going bigger, your cohort's going to get bigger. So for us, we're quite happy just to do the R over 85s and get on with it, because we know that number is going to be small based on our list size, etc. etc.
Yeah, and just the problem I think, John, is that's not going to be at this point. That's not going to be an option to us for a practice to deliver just to their own over 85. So you've got to receive the 1,000 vaccines at a go. So unless you've got more than 1,000, and the letter is explicit in saying that practices need to work within PCN groupings. So if your practice can be used, if it's designated as a building, it would need to be working with the sort of surrounding practices, neighbouring practices, to deliver to that wider cohort of over 85 patients. So that's what James Barker and Mirban will be coming out to practices to talk about today, I think.
Okay. That just ties your hands, and it just explains how the NHS works.
Okay, but I think what we're doing here as a governing body is assuring the public of Barnsley that we're aware of the new development of the vaccine, that we're putting plans in place to deliver it safely and timely, and to get the maximum coverage that we can. I think a lot of the detailed discussion that we've had is, again, logistical, and I think the answers to this will probably line practices and primary care at scale, and it's probably a discussion that we should continue outside governing body. The importance of bringing this up at governing bodies so the public are aware that we're on the front foot with it and that we're doing our best as a commissioner to deliver. So thank you for that. A little bit more than I expected, but we've been open and had a good, robust discussion about how we're going to do this in public. Can we move on then to item 12, the community service?
Thank you.
Yep, thanks, Nick. So got the paper in front of you. We've obviously heard the patient story and seen the engagement summary from Kirsty as well. Really good piece of engagement. I'd like to sort of pass on my thanks for that as well. Everybody is aware clearly that we've got an active procurement process underway for this at the moment. So we're limited in what information we can share other than that which is outlined in the paper. Just also to note that Dr. Harvin, our CCG clinical lead for respiratory, has to temporarily step aside during the procurement process. It's just to support the management of our conflict of interest process. So that's why I'm presenting the paper today rather than John.
Thank you.
So what we're presenting is that following decision to go to procurement process, we've undertaken that engagement piece, which has gone, I think, really well, and we've used the feedback from that to influence the specification and made changes in the specification as a result. So we've already heard quite a lot about the engagement. We're going to focus on changes in the spec, and then I'm going to ask governing body just to note the engagement report and the use of our response report, which is in the appendix 1 and 2, and then to note the final breathe service spec, which is appendix 3, and the key service principles in appendix 4, and the KPIs in appendix 5. So back on to the key changes. I can summarise those, but they're in section 5.3 of the paper in slightly more detail. So the key changes are to ensure the requirement for a community respiratory, that's all respiratory services, out of hospital, with the main principle being that patients seen and treated in the community and managed in their own homes. So that is really clear and emphasised within the specification. Main principle of service delivery is for a service that supports people to stay well at home by proactive care, by risk stratification of patients to pick up concerns early, and crucially the use of multidisciplinary teams to coordinate specialist input. And that includes integration within our neighbourhood team model, which we are in the process of mobilising. So that brings us back to some of the points you were making earlier about ensuring patients have access to the full range of services that they could need, including mental health services as well, where that would be appropriate. So what we're trying to do then is align the specialist service to the neighbourhood team model, including clock speed response times, which are in the neighbourhood team specification and now in this revised specification as well. So we've expanded the scope of respiratory conditions treated, including coronavirus pathways as well, post recovery. And we're also clarifying the joint clinical leadership, importantly via a named lead respiratory nurse and a named community consultant to provide expert clinical input and clinical leadership to support admissions avoidance and the care of patients under the GP and neighbourhood teams. So we think that's key and that is an important part of the specification. Those are the key points I wanted to draw out. Clearly, there's a lot of paperwork there in front of you, outlines the ask of governing body, and really open for questions. And my colleague David Lightman's on the line as well now, in case there are any points of detail that we want to go into.
Hi, David. So Any questions? So we're happy with the engagement reports and we're happy with the final Breathe spec. Yep. I think that's really good, and I think that brings to a conclusion a long period of development and work on the Breathe service, and hopefully we can now move forward with that. Okay, thank you, David, Jeremy, John and your teams and all who've been involved, and actually the governing body, because we've all been pretty heavily involved through looking at different versions of this over the past couple of years. Good. Can we then move on, please, to Jane, Quality Highlights Report, item 13.
Okay, thank you, Chair. So the Quality and Patient Safety Committee would like to highlight 4 areas to the governing body today. The first to highlight, which is RAG rated as green, is the development and approval at QPSC of a children and young people's continuing care appeals and dispute resolution process. As the governing body are aware, the CCG quality team have reviewed the children's continuing care service, pathways and processes, and is making significant improvements in this area. The development of this process will ensure that the CCG has an effective and efficient formal mechanism to manage appeals and disputes about children and young people's continuing care. The second to highlight, which is also RAG rated as green, is that BHNFT is introducing a new patient experience initiative, which will consist of regular informal drop-in sessions with patients and carers, either in person or virtually, obviously adhering to COVID restrictions, and the CCG will be part of this group. The aim of the sessions is to obtain a much wider range of patient experience feedback other than the normal complaints, compliments and the friends and family test. So QPSC welcome the new initiative, which will provide a much richer source of patient experience feedback. The third to highlight, and RAG rated as amber, is in relation to the progress of the CCG's review of maternity incidents, which have occurred at BHNFT since April 2019. The CCG is awaiting the completion of all the incident investigations so that we can obtain a full overview of the learning and action plans from the incidents. So although there are 4 investigations outstanding, the CCG designated nurse for safeguarding children and the CCG quality manager have met and have pulled together an analysis of the incidents we have, the learning and actions, and have highlighted the key themes. This was sent to me last night, with the analysis being on the agenda at the next Quality and Patient Safety Committee. The final area to highlight to the governing body, and is RAG rated as red, is with regards to SWIFT's Adult Community Speech and Language Therapy waiting list for patients with communication needs. The committee was informed that referrals into this service would have to cease, as currently the Trust was not able to offer a service. Members were notified that patients would be referred to other providers outside of Barnsley, and the CCG is currently completing an equality impact assessment for the service change, and communications had notified relevant stakeholders. The Quality and Patient Safety Committee agreed that the progress of improving the management of all of SWIFT's waiting list needed to be monitored closely by QPSC and updates provided to the governing body accordingly. So, Chair, thank you. These are the 4 areas that the Quality and Patient Safety Committee wanted to highlight to the governing body, and I'm happy to take any questions.
Could I ask Jane, with response to SWIFT waiting times, is that being followed up? So that's the Clinical Quality Board. Do you have a governing body GP on that with you? Is it Mark?
It is, yes.
Yeah, okay. Any other questions for Jane? Can't see any. Thank you, Jane.
Thank you.
Can we then move on to item 14, Richard, the Risk and Governance Exception Report, please?
Yeah, thank you, Nick. So you've got the paper and a few appendices which you'll have already seen. So I'll just pick up a few of the key sort of points I wanted to raise. There's a section in there on the governing body assurance framework, which, as I've picked up at a couple of previous governing bodies, We have sort of been working on a refresh of that over the last few weeks as we moved out of the first phase of the COVID peak. The updated and refreshed GBAF is now in your pack for you to take assurance from, and also to approve if we can. The priority areas that are contained in it are effectively the same as they were in the sort of 1920 GBAF, although some of the specifics in there have changed a little bit. And we have also added in one additional area, which is around provision of care in care homes as well. So as I say, so that's where we are as far as the GBAF is concerned. There are currently 2 of our priority areas where we're flagging as being red risk, i.e. we see there being a fairly significant risk that we might not achieve the deliverables in the year. That's around cancer and also around sort of financial balance and efficiency planning. Moving on to the corporate risk register, again, you've got an excerpt in the papers of the red and amber risks from the risk register. They now incorporate both those 5 risks that we were sort of carrying as we came into 2021 at the start of the COVID peak, and they also include 3 or 4 additional risks that have emerged during COVID and which we've now sort of merged in with the other risks on the corporate risk register. So again, those are there for governing body's assurance that they are being managed and mitigated. And also, obviously, you know, if there's any questions on that or anything that anybody thinks is not reflected in the risk register, this is the opportunity to say. Just a couple of things then for governing bodies assurance. Firstly, around committee terms of reference, we make sure that our committees review these at least on an annual basis. This is just to confirm for governing body that audit committee and finance and performance committee have reviewed their terms of reference recently, and neither of those committees are proposing any changes to those at the moment. Likewise, the decommissioning policy, this is something that we have to review every 2 or 3 years in the same way that we do all our policies. This has recently been reviewed by Jamie in conjunction with others in the CCG, and has been taken through the Finance and Performance Committee, and again there's been some minor changes, but it's been updated and will now be available should anybody wish to see that on the CCG's website. Workforce report. So every quarter we receive as a CCG a report from our HR team, which gives us some information around staff turnover, staff sickness absence, and training compliance. This is always taken through management team, but when we were discussing it at management team a year ago, we felt this might be something that governing body would find of interest, if not every quarter, then at least once or twice a year. So I've just I've included as an appendix the most recent workforce report that you've got. And I think what the key takeaways from my side is that it's showing that despite everything that's been going on over the last few months, we've had low and stable staff turnover, low rates of sickness absence in the CCG, and the rate of compliance with mandatory training continues to be pretty high, really. And the final thing I just wanted to pick up on is the governing body work plan and agenda timetable, which again Kay keeps this sort of up to date on a regular basis, and we bring it into governing body just so that people can flag if there's anything that they think is missing or scheduled in the wrong place or whatever. So that's there for assurance. One thing that we will be doing to that now that we've got the GBAF up and running again is looking to schedule in sort of routine reports, probably a couple of times a year, for each of the priority areas in the GBAF, so that governing body is getting that sort of detailed assurance against each of those priority areas. As I say, at least a couple of times really in each year. So that's all I wanted to say. Happy to take any questions or comments.
Roxana's got a hand up.
Yeah, it was just a comment, Richard. I'm just on page 2 of the timeline, so it'll be the budgets for the 21-22 year rather than 2021, because that's obviously current year.
Yeah, okay.
That'll just need updating in the work plan.
Smashing.
And then the November date in there for operational planning for next year is obviously delayed due to COVID, so that will need to come out as an update to the governing body.
Okay, thank you.
Any other questions or comments for Richard? No? So you're comfortable that we've had the information and completed the governing body ask, Richard?
I think so. I'm just reading through the ask as I speak. So we've reviewed the assurance framework and risk register.
Yeah.
I'm taking it that people are happy that risks are being appropriately managed, and that there's no new risk that anybody wants to be added at this stage. We've noted the terms of reference. We've noted the decommissioning policy, noted the workforce report, and received and commented on the work plan. So yes, I'm happy that we've covered the ask. Thank you.
Okay, so if there are no further questions or comments, thank you, Richard. Thank you for that and all the work that's gone into it. We then move on to item 15, the integrated performance report. Roxana, do you want to, or Jamie, do you want to do your bit, and then Roxana can roll into the financial plan with the financial bit? Jamie.
Yeah, happy to do that, Chair. That's fine. So usual format in terms of performance reporting. I think worth, as we've done previously, just noting the expected impact in terms of COVID and the ability of our providers to see, and that's showing through. So in terms of the attachment that you've got that shows the position, I think it's just worth noting that we do continue to see that adverse impact of COVID, including on the delivery of some of the constitutional standards where, historically in Barnsley we've been very good, such as the referral to treatment times and waiting times for diagnostics. What I would say is the position in September was showing sort of positive moves, so performance was improving as the hospital and other providers started to sort of pick up activity. My expectation is that we'll probably see that fall back away on the back of what we've reported earlier in terms of the numbers of patients and the pressures in the hospital. So I think that's there. I think it is worth highlighting, because it's been picked up before, the impact that COVID had on long waits, including some of the cancer waits. So at a CCG level, based on, this is August position cancer because it's a little bit later, but at August we were seeing improvements across all of the measures as a CCG, and that includes our patients when they need to go to other providers. But I think on the right hand of the Barnsley position, for every one of the cancer measures, other than the one where we talk about consultant upgrades, they did achieve the standards, so they were all on green. So I think the trust had quickly got to a position where they were delivering again against those standards. The other point just to make in there, you can see it through, so the urgent care, we don't talk a lot about this because of the way we manage, but you can see across the ambulance response times where we'd had some improvement and seen good response times. There's some challenges there as well. And then I think worth noting that across our IAPT services that there's performance against all the indicators is positive. There's one that's currently red, which is the access target, which it has been for a while, but the performance at the moment is the best that we've seen for the beginning of this year. So you can see in the CCG performance, the sort of trend line, the red bars, that's getting less and less. So we're getting closer to that target. We need to get there to support patients, and I would expect the numbers to start to ramp up. And Patrick is working with the service on that to make sure that coming out of COVID, linking in with the COVID sort of recovery work, the COVID rehabilitation services and them things, that actually access to that service we should see increase quite a lot, and demand will be increased, I would expect. So that's what I wanted to pick out from a performance perspective.
Okay, any questions for Jamie? No, thanks, Jamie. So, Roxana, do you want to take the financial elements and then move into item 16, please?
Yep, thank you. So key points to note in the paper is that the month 6 top up that we of 2.4 million. So we're still waiting for NHS England to confirm that that funding will be received. That it's still going through some governance and assurance, but we expect notification of that later this month. So that could potentially be a risk to the CCG if that resource isn't received in full, because none of that is captured in our financial plan for the period months 7 to 12. Just in terms of COVID expenditure, so as agreed as part of the delegated approval process, included in the report in section 5.2 is our details of all COVID expenditure claimed for up to month 6, and also things that were approved through SMT Gold Command as part of the delegated approval process. So those are just included in the report for the governing body to note. We obviously continue to monitor those costs as we move into months 7 to 12. As when we move on to the budget report, you'll see we've now got a 6-month allocation of 1.768 million. So we do need to ensure that costs are managed within that financial envelope. And that's obviously before we receive any additional funding for primary care, which we've obviously been notified of this week. So I'll just pause there to ask whether anybody's got any questions on the up to the month 6 position before we move on to the financial plan. No? Okay, thank you. So just in terms of the months 7 to 12 budget position then, so obviously governing body are aware we've had significant discussions around the position. The plan's now been submitted. We've got a 4.4 million efficiency requirement included within that plan. The plan we submitted also included quite considerable unmitigated risk. So therefore, those are kind of pressures that we might see coming through into the CCG, but because of the lack of contingency that we have within our budgets, we will not be able to deliver essentially a balanced budget position if those risks materialise. So that unmitigated risk was around 2.4 million. Now, clearly, we need to do whatever we can in our power as a CCG to ensure we deliver on our financial duties. So discussions do remain ongoing in terms of ensuring that the budgets in place are appropriate, ensuring that we have contractual or commitments against expenditure, and where we don't have expenditure commitments, budgets will be removed, because we're not in a place whereby we can allow any sort of flexibility in budgets. Discussions are also ongoing with NHS England with regards to the growth that was factored into CCG allocations around continuing healthcare and prescribing. They've recognised some of the pressures in prescribing nationally, and that the modelling assumption was indeed probably flawed in its assumption. But what they've not done at this point is provided any additional allocation. All they've done is acknowledge that the modelling that they did do nationally was probably understated the level of growth that was required in prescribing, because what it didn't do was capture any sort of impact of QIP delivery. It assumed that QIP would continue to be delivered throughout the course of this year, which clearly hasn't been the case due to the COVID impact. So it is intended that we essentially go through budgets in months 7 and 8 with a level of scrutiny and see what flexibility, if any, we can take out of budgets to kind of close the gap. We'll continue to report and monitor the budgets as we do within the finance and contracting team, and report that through to Finance and Performance Committee in detail. But the ask of the governing body today is to essentially approve the budget for uploading to the ledger. It has been supported through the Finance and Performance Committee, so there was a detailed discussion at the Finance and Performance Committee, and the governing body are asked to approve it, recognising, of course, that it's not the first time that the governing body have been presented with this information. This is just the formal approval process.
Okay, we okay to approve that? Seen it all before? Yeah, okay, thanks Roxana. At that point, we move on to a series of committee reports and minutes. So we have item 17, unadopted minutes, audit committee, 14th of October. Taking these as read. Nigel, is there anything you want to draw our attention, the governing body's attention to particularly? No? Nigel?
Sorry.
Oh,
Sorry.
I thought it was my end again.
No, it's me. Yeah, I think we could take them as read. I mean, we received a number of assurance reports from various different parts of the organisation, and we approved our terms of reference. And other than that, it was a standard meeting.
Okay, so if there are no questions, thank you, Nigel. We'll move on. So 17.2, we've got minutes of finance and performance. These have all been adopted already, and we've approved the financial plan. So they're the 3rd of September, 1st of October, and 15th of October. I think they're at this point there for assurance. Are we happy with those, and can we move on? Yeah. Okay. So we then move on to 17.3, minutes of quality and patient safety, minutes of the Primary Care Commissioning Committee, 24th of September. Chris, is there anything you want to?
Yes, if I may, as much for the governing body as it is for the members of the public, in that James Barker, the Chief Officer at Barnsley Healthcare Federation, attended this committee to inform the members of the support that's been extended into the primary care network. The positive message that we opened with was, since the start of this pandemic, all of our practice a dedicated clinic called Blue Clinic had been established in the medical sector at Cambridge for those patients who had or were suspected to have COVID, keeping them away from Jamie White has reported earlier that the contract for the Blue Clinic has in fact been extended. So I won't cover that. Up to the time of our meeting, James reported that in fact the Blue Clinic had supported over 1,000 patients, which is extremely positive for the people of Barnsley. He also told us about an ambitious plan to recruit 79 whole-time equivalent staff, and this would cover a number of roles. The recruitment process was well underway, because I queried it was ambitious, but no, he is quite positive about that, and in fact he confirmed that offer has already gone out to some of the successful applicants. So for the sake of good governance, there is also attached within the papers the adopted minutes of this committee covering January, May and July. Happy to take any questions. Hello? Nick, can you hear me? Hello?
I can hear you, Chris.
I can hear you, Chris.
I wonder if Nick's, is Nick frozen now?
I think so. I think the advice from the chair was if he did freeze, Chris, for you. Oh, I think he might be back.
It's just on mute.
Okay. Nick, are you back?
Never been back.
Well, actually on my screen he's been frozen out for quite a bit of that.
He has. Chris, do you want to take over proceedings just while we wait for Nick to return?
I will. So on to item 17.4, Jane, members of the minutes of the Quality and Patient Safety Committee held on the 20th of August.
Thanks, Chris. Nothing to add really, because obviously I'll take it as read, but just for noting that the Quality and Patient Safety Committee has met since the 20th of August meeting. They met on the 22nd of October, where these set of minutes were approved. So just for noting.
Okay. We may struggle on 17.5 unless either Jeremy or Jamie White can pick up that point of the minutes of the Health and Wellbeing Board, which occurred. No, head of shaking. Jeremy, are you able to?
Yeah, so I guess the key point just to note from the minutes is that Health and Wellbeing Board are in the process of establishing a mental health alliance. So that'll be a key focus for Health and Wellbeing Board in the future. That will be set up in the new year. So that's again, just a question of timing in response to coronavirus. But I think that's an important thing for us to note.
Okay, thank you. So moving forward again then on to item 18, which was the general point. We've all got earlier circulation from South Yorkshire and Bassett Health Executive Group of their meetings, and there were various enclosures, including the flu planning update. So again, if there's any questions in relation to those bits and pieces of information that came out before the start of this meeting, again, I may need some support from either Jeremy or Jeremy on that. Any questions, or even Chris Edwards? Chris, do you want to comment on that?
I hadn't got anything to add particularly. I don't know if you, Jeremy, did you have anything to add?
Not in particular, no.
Okay, thank you. Well, we're moving into item 19, which is a reflection on how the meeting has been conducted. First and foremost, what I want to ask on behalf of the chair is that, are you all happy that the papers that have been presented today came in good time and were of the sort of quality that we could all very quickly understand to prepare ourselves for this meeting prior to it actually happening? Everybody happy with that? Okay, is there any other areas of assurance that we need from that other than the items that have been agreed to be taken out of this meeting, particularly some of the nitty-gritty on the vaccine, how we're going to run it, where we're going to run it, that sort of thing. So that will be a very out of this meeting executive putting things together. Any training needs for anybody? Okay, so all being well, the date and time of our next meeting will be Thursday, the 14th of January, 2021, which is quite something really when you think about it. 2020 has been different, hasn't it? So with your permission and the chair's permission, who is not with us at this moment in time.
Hi, Chris.
Thank
you for doing that.
Thank you
for doing that for me, Chris.
Jamie.
Are we okay to just have 15 minutes break before private then?
Yeah.
So if we touch up, if we catch up again in 15 minutes.
So we're starting again at 11:30, yes?
Yeah.
Okay.
And just